Great.
Yeah.
Okay. Hi, everybody. This is Dr. Carol. I don't have like the nifty blue color slides. Welcome to the practitioner webinar for January 2017. I spent last week at Cleveland Clinic treating patients. And so these case reports that we're going to do today are taken from both the core seminar and the 2 days of patient treatments in the outpatient unit that we did. This first one, it's entirely possible that you won't ever think of this or see it. But the reason I put it first is that it was a demonstration of how the effectiveness of the frequencies ends up being diagnostic. So 40 and 396 always treats and quiets down nerve pain. It's predictable, it's reliable. In 22 years, it's never not worked. So that ends up helping with your diagnosis. So it's a TBI, traumatic brain injury case. The history was that he's a 17-year-old male. He fell off of a skateboard 2 years ago. He did not have a helmet. Board went out from under him. He went flat on his back, fractured the back of his skull, and on the left in the back, and at the right temporal lobe. Did not require surgery because they weren't displaced. His imaging showed a subarachnoid hemorrhage, subdural hemorrhage. There was a fair amount of bleeding around the fractures. They did not need draining, as I recall. He was unconscious for about a week. He has traumatic brain injury symptoms. Those have been improving over the last 2 years. He's a little more ADD than he was before the fracture and the head injury. Very, very pleasant, alert. Speech and motor is pretty much okay, except he has a brace on his right arm, right forearm. His chief complaint is thoracic outlet, right arm and chest pain that has been diagnosed as thoracic outlet syndrome. Scalenes are super tight, his neck is tight, his upper chest is tight, and his right arm is so painful it's hard to touch. He has difficulty raising his shoulder. And nothing has been successful so far in treating the right arm. So he's had PT, massage, trigger point therapy. Graston is torture, but it seemed to improve his function. And he had acupuncture. So none of the above worked. Great. So the physical exam, I didn't use a pinwheel because I didn't have one. But his subscapularis was incredibly tender. So +4 out of 4 means very light pressure makes for withdrawal and extreme tenderness. So the subscap was very tender, kind of what you'd expect in thoracic outlet and C5-6 nerve root. So I went in thinking that what we were dealing with was a 5-6 disc that had jacked up his right shoulder and right arm at the time of the head injury. And that the subscap was what was limiting his shoulder pain, kind of like the typical neck shoulder impingement story that we expect. You see it all the time, right? So his right forearm, his right upper arm, his anterior neck and chest were likewise +4 out of 4 tender, tight, except the forearm was almost flaccid. There was not a lot of muscle tone. I attributed that to the brace that he was wearing on the wrist and forearm. And he primarily wore the brace to keep from moving the wrist and also to keep people from touching it. So treated from neck to the right axilla with 40 and 396. inflammation in the nerve, 13 and 396, scarring in the nerve. And then we moved, because his forearm was so tender, and the subscap actually didn't improve much. So I went to his right hand with 40 and 396, the nerve, inflammation in the nerve, 40 and 710, the disc, 40 and 10, and nothing changed. It did nothing. 40 and 396 did absolutely nothing for the pain in the forearm, especially. Actually, it didn't do much for the subscap either. And 40 and 396 never doesn't work. So it occurred to me to ask the mom when the pain started. If it had been a neck, disc kind of nerve pain injury, you would have expected the pain to have started, a couple of weeks after the head injury and the neck injury. And mom said the pain started gradually about 1 year after the original injury. He had no additional trauma. He's had no trauma since the head injury. No activities commonly associated with thoracic outlets. So he doesn't type a lot. He doesn't play the guitar. He doesn't do much of anything that would be associated with thoracic outlet. The pain has been progressive, so it started in the arm and hand and has ultimately involved the whole right arm, the neck, and the chest. Back of the neck, and as well as the scalenes, the anterior chest. So I moved the contact from his axilla to his hand, and so the contacts were now on the neck and the hand. And I started to run 40 and 89. The thing you need to know about thalamic pain syndrome is that the bleed that starts the injury, so the first thalamic pain patient I saw had hemorrhagic stroke when he was 27, and he started with right-sided body pain when he was 35. I saw him when he was 42. So thalamic pain syndrome from subdural hemorrhage and from bleeds comes on gradually after the original bleed. So mom said the pain came on gradually over a year. That made me think of the midbrain as a pain generator. Fortunately for me, I had Dr. Catholi there at the Cleveland Clinic Pediatric Rehab Department. And I said, how is the homunculus? He's a PM&R trained doc, which means he has a fair amount of neurology. How is the homunculus organized in the sensory cortex and the thalamus? And he said, sensory cortex has the arm, upper body and arm at the inferior portion of the sensory cortex, and the and kind of the outer portion of the periventricular sort of thalamic area. So I started with 40 and 92, actually, and that took the pain down a bit. But 40 and 89 is what did the most good. So I'm going to change the slide a bit. So I started with 40 and 92, figuring it might be the sensory cortex leading to hypersensitivity. And when that started reducing the pain, I went to 40 and 89. And within 20 minutes, the patient is fighting sleep. He's a little bit ADD. So he was fighting sleep. And I said, this is going to make you feel really floaty. You might as well relax and enjoy it. So about 20 minutes, he was sound asleep. I could palpate his arm. It was not tender to touch. His pain level was 0. What was interesting is that the flaccid forearm muscles started to fill in, get more tone, not spasticity, but it went from sort of flaccid to just more tone, more normal tone. I ran trauma in the medulla, and after a minute or two, he started to become restless, so I went back to 40 and 89. I ran that for 5 or 10 minutes till his pain went back down. And you could tell because you could palpate him in a wasn't painful. Went to 124, torn and broken in the midbrain, the thalamus. After a couple of 3 minutes, his arm became painful again and he sort of got restless, went back to 40 and 89. So I got the basic sequence done: 94, 124, 321, reboot, 9, allergy reaction. I think I actually did vitality in the forebrain, in the midbrain, the thalamus. And in between each one of the basics, I had to run 40 and 89 for 10 to 15 minutes to keep the pain down. Then at the end, went back to 40 and 89 and ran that for the last 20 minutes. He was completely out, just out. I moved the towel from his arm to his chest at one point, because once we got rid of the arm pain, then what was left was the chest and scalenes and neck. So move the towel up to those areas, and the chest and the neck muscles relaxed and the pain went down. So it was another illustration that when you're treating a nerve, the contact has to be where the nerve ends. I sort of expected neck and hand to take care of everything in between, and that wasn't the case. I had to put one of the towels up in his chest and his lower neck to keep that pain down. So Dr. Carbat was there. She's at the Functional Medicine Center at Cleveland Clinic, and she was helping us out in the pediatric rehab center for the day. And she treated with a second machine. Basically, we had the towels at his neck and his hand. I had a washcloth on his hand. We had 2 machines connected to the towel around his neck, 1 machine connected to the hand, 1 machine on the towel that I had, that I moved from his armpit to his hand to his neck. And Paris and Dr. Carbat ran kind of 94 and 94. She treated the medulla, the hindbrain, because he was having a bit of problem with balance and coordination a little bit. Forebrain, 90. 84 is the hindbrain, 92 is the sensory cortex, 783 is, and he had a headache. He had tenderness in the skull. 783 is the periosteum, and 187 is the skull as a unit. It's also the occiput C1 joint. She treated those 2 for inflammation and torn and broken. She treated the brain parts for trauma and inflammation, I think. Also treated the pia and the arachnoid and the dura. We have frequencies for those of you who have not been to the advanced. Those frequencies are at the advanced, the dura, the pia, and the arachnoid. At the end of we had about an hour and a half for each patient. So 30 minutes for the history and about an hour for treatment. At the end of the hour, the patient was pain-free, his headache was gone, his skull was non-tender. And then this is the hypothesis that drove the treatment. The homunculus in the sensory cortex has the neck, the arm, the shoulder at the bottom near the thalamus. My hypothesis that developed in response to his response to treatment was that the brain bleeds bled down, so the subarachnoid and subdural bleeds bled down into the thalamus, leading to periventricular neuronal damage. I don't know what you call it when a bleed causes scarring in the thalamus, leading to thalamic pain limited to the right upper extremity. Now, there's a chance that over time, so this has been only a year with the awful right arm pain, there's a chance that over time the thalamic pain may spread to other parts of the thalamus unless we're successful in treating it. So he left pain-free, but I told both him and his mom, so he's 17. I told both him and his mom that the pain relief is unlikely to be lasting. How long it lasts will give us an idea about the ultimate prognosis. Custom care may be required for home treatment and palliative care. With thalamic pain, even if you can't get rid of it, the idea that the pain can be relieved, even temporarily, is pretty extraordinary. They don't have him on, I don't think, any pain medication. And it's just as well because there's nothing that would work for thalamic pain anyway. The final treatment is not broadcasting. Okay, so we just got a note that for some reason we're not broadcasting, but we should still be recording this, I hope, somehow. We have 2 people watching, which I guess is me and Kevin. And I'm not entirely sure how that's going to work, but I'm going to keep talking. I've got 14 slides. Do we have any feedback from the people that are trying to watch?
Yeah.
Like, where are you?
Brittany's letting know.
Okay.
We'll send it out.
Okay. Alrighty. Where are we? Oh, okay. So, so my ending suggestion is like the physician, a PM&R physician that was there, was still sort of attached to the thoracic outlet diagnosis. And I said, yeah, it's not thoracic outlet. This is central. It's thalamic pain. And we recommended, so he and I agreed that there should be some sort of brain imaging, probably just an MRI, perhaps an MRI with contrast, but some sort of MRI brain imaging to verify the thalamic scarring and the thalamus as a pain generator. By the time the thalamus begins being a pain generator, there are usually tissue changes. It takes about a year to up to 5 years for the thalamus to have enough change in function that it will become a pain generator. The imaging is going to be required to change his working diagnosis for insurance and purposes, to change the diagnosis from thoracic outlet to thalamic pain syndrome. The frequency response is obviously not sufficient to tell the insurance company that, yeah, it's not thoracic outlet because 40 and 396 didn't work. It is central pain because 40 and 89 did work. So we can't use the frequency response officially as diagnostic, but from a clinical perspective, it obviously is. So you'd want to do an MRI to confirm the diagnosis and then continue to treat him. He's going to need a custom care. I've never had a thalamic pain case where it was permanent unless we got it immediately at the time of the stroke. This is 2 years post-injury. So we're there. So this week in Cleveland was fascinating. We had a patient, I think she was a practitioner at the seminar, actually. She had a small bowel obstruction requiring a liquid diet. Now, her original history said a small bowel obstruction after ovarian cancer. So we were working on just scarring in the bowel, 13 and 77, 13 and 22. It turns out she's had 3 hospitalizations in the last 5 years, requiring a liquid diet, like a week of just letting the obstruction clear. She's had full body pain since before the ovarian cancer, worse. Oh, yeah. And then she had breast cancer. So she had ovarian cancer first, and then she got breast cancer. This was all, let's see, ovarian cancer was 2008. She had chemo and surgery, but no radiation. It turns out, after we started treating her, she said, oh, yes. It's like the small, this was a patient actually we brought in on Saturday night, now that I think of it. She had the small bowel obstruction, which after removal of the ovary and chemo, honestly doesn't make any sense. There's nothing they do when they remove the ovary that would cause a small bowel to obstruct. So as I'm treating her for the abdominal adhesions, and she had radiation for the breast cancer, but those adhesions are going to be in the upper body. They wouldn't affect the abdomen. The question became, what is causing a small bowel obstruction after something so simple as removing an ovary and using chemo? There's no reason the small bowel would obstruct. So I'm looking for, and it's on the right. It was the left ovary and the right small bowel, right lower quadrant portion, the lower portion of the small bowel. And so I'm treating her, and all of a sudden, it was either her clinician, somebody said, oh, by the way, they had to remove the lymph nodes around the aorta. They wanted to make sure that there was no cancer in any of the lymph nodes. So they removed the lymph nodes at the aorta, and that was the clue that said that that said how it was the small bowel got obstructed, got compromised. When you need to address the lymph nodes at the aorta, if you look at that page in Netter where the intestines are removed and you look at the periaortal lymph nodes, there's no way to get to them if you leave the intestines in place, right? So when you re-listen to this, pull Netter out and look at that picture. There's no way to do it. So when they do that procedure, the resident or the assistant surgeon, the PA, will literally take the intestines out and put them in a saline bath or on a tray next to the patient on the operative table, so it's sterile, safe for the small bowel. But I don't know if you've ever seen abdominal surgery. The intestines are kind of slippery, right? They don't stay in one place. They're slippery. Think of a bowl full of cooked thick spaghetti. They wiggle around. So somebody loosens the fascia, takes the entire intestinal contents out, the descending colon, because they're looking to access more on the left than the right, descending colon, the small bowel, and the upper left part of the transverse colon. All of that goes off to the patient's left. If a portion of the small intestine fell over on its neighbor, so if it just sort of folded over and restricted the circulation for the hour and a half to 2 hours or so that it would take to remove the lymph nodes at the aorta and to remove part of the omentum, it wasn't enough obstruction to make the small bowel ischemic, but it was enough obstruction to cause scarring in about 2/3 of that segment of the small bowel. So that's how you make sense of, to me, you always want to make sense of how we got here, right? So the small bowel would obstruct, but it wasn't necrotic. It didn't die. They didn't have to go in and take out 5 inches of her small intestine. They just let it sort of settle down and open up. Okay. So that's how the ovarian cancer in 2008, so this is 2017, so it was 9 years ago, led to these 5 hospitalizations, these 3 hospitalizations in the last 5 years. Now, why did it take between 2008 and 2012? Why did it take 2 years for the scar tissue in the small bowel to get bad enough you had to treat it, or that it obstructed things? Can't tell you that. 4 years, so it was 5 years, 2012 was when the small bowel started obstructing, and 2012 was when she got breast cancer. So she had a 3-centimeter tumor, she had a lumpectomy, chemo and radiation, and if you have genetic factors or constitutional factors that predispose you to scar tissue or fibrosis, 2012 was the breast cancer, 2012 was, so 5 years, 2012 is when she started getting hospitalized for the small bowel obstructions. So you could make a case for it from an FSM perspective. Her abdomen was +2 to 3 tender. It was firm with right lower quadrant the most tender. When they're that tender and it's been that long lasting, you want 1 unit neck to feet running 40 and 10 to reduce the central sensitization and reduce the pain. We had, it was one of the practitioner's patients. She had the patient come in. Now I remember. We had a 2nd unit on the back and the abdomen. We were running scarring and the connective tissue, scarring in the small bowel, scarring in the adipose because she had a partial removal of her omentum. The treatment was going very slowly. And at the same time, we were treating this patient. I had students working on this patient, and I was treating the next case that you're going to see in the next case report. I was seeing that patient on the table right next to it. After about 30 minutes, she should have been much farther along. So I went over to the table and I said, "This is really slow. Have you had any water to drink?" And she said, "No, I don't drink much water." And the practitioner had forgotten, the practitioner that invited the patient to come and be a demonstration. So we did this case at 6 o'clock on Saturday night. She forgot to tell the patient to drink water. So she wasn't hydrated, she wasn't told to drink water, and doesn't generally drink water. So she was a lovely lady, normal body weight, good skin tone, appears healthy. So she's not cachexic, she's not ill looking, she just isn't hydrated. So we paused the treatment, had her drink about 16 ounces of water. She just chugged it right down. She was a good sport. And then they went back and treated her again. And 13 and 77, scarring in the connective tissue, took care of the scarring around the edges of the peritoneum, scarring in the small bowel, scarring in the arteries of the blood supply. So if you look at the model for why she had the ischemic, why she had the scar tissue in the small bowel, it involved ischemia to a portion of the bowel as a result of having the bowel removed and having a piece of the small bowel fold over on itself and restrict the circulation for about an hour to an hour and a half. So the artery, the arterial supply to that section of the small bowel is the arterial supply to that section of the small bowel is restricted. So you want to treat scarring in the artery to maintain the circulation to the small bowel. And then she had part of her omentum removed, scarring in the adipose. And because of the generalized surgery, her abdominal tone, it was sort of rigid. So we did scarring in the fascia, which I don't usually do in the abdomen. And the scarring in the fascia softened the general abdominal rigidity and tone. I mean, it wasn't an acute abdomen. It wasn't that kind of rigid. It was just stiff. So the treatment was much more productive. The doctor that had invited her to come is local and purchased a custom care and a precision care, I think. And so the treatment plan was for that physician to do the concussion protocol and to repeat the frequencies for scarring in the connective tissue, to remove the adhesions in general, scarring in the small intestine, 13, scarring in the arterial supply to the small intestine, and then scarring in the fascia. You would also want to do probably scarring in the adipose, because they didn't do all of the omentum, they only did a portion of it. That particular surgery is a pretty tough way to get a tummy tuck, actually. Now, the physician whose patient this was works at Cleveland Clinic, and so she's able to see this patient on an ongoing basis. After she finishes the abdomen, she is going to be working on the scar tissue in the patient's chest from the breast cancer. I would say remove radiation, 54 and 10, and probably 13. With the blood supply, 62, 142 the fascia, 77 connective tissue. And if you look at where the radiation beam goes, it's going to go through the spinal cord, it's going to go through the nerves, it's going to go through the blood supply, and go through the lungs. The challenge with radiation therapy is that the cancers that are caused by the radiation show up 5 to 7 years after the radiation therapy. So if we're going to help prevent those, we need to treat for radiation, 54 and 10, scarring, and sometimes inflammation in every tissue that, especially cancer-prone tissues, that are in between where the beam hits the body and where it goes out the backside. So just because you radiate the breast, the radiation beams do not stop at the breast. They don't stop at the chest wall. They don't stop at the bone. They don't stop at the spinal cord. They don't stop at the lung. Any cancer-prone tissue is susceptible. So, and then scarring in the connective tissue, 13 and 77 connective tissue, the fascia, and the small bowel. That's going to have to be repeated. So just as a food for thought, a patient has ovarian cancer in 2008 and breast cancer in 2012, 4 years apart. So you're obviously going to want to run the concussion protocol, right? So that's sort of to take the constitutional factors that lead to cancer out of the picture. So you run the concussion protocol, but both of these cancers are hormone related. Okay, what does that tell you? It tells you that her body, her liver, turns estrogen into an inflammatory fragment of estrogen. And it also tells you that her estrogen-sensitive tissue cannot methylate. If you can't methylate, you can't stop the genes from opening up and becoming carcinogenic. So you might want to explore her methylation genes So the MTHFR, whether or not she can methylate folate, whether or not she can methylate B12, what are her methylation pathways? Can she phosphorylate B6? Can her liver detoxify estrogen? Because if she had ovarian cancer and breast cancer 5 years ago, at some point, there's going to be another estrogen-sensitive tissue that's going to develop cancer. So in addition to treating the scar tissue that she has from the original episode, you're going to want to explore the physiology of estrogen. Okay, estrogen detoxification in this patient, right? To correct and prevent the next cancer that is almost certainly going to appear. That's kind of a functional medicine approach to this patient. She was very positive. She came with her husband. He was very supportive. So I don't anticipate, I mean, there's not a lot of emotional component to this. This is chemistry. This is physiology. She turns estrogen into inflammatory products, and she cannot methylate the genes in the estrogen-sensitive tissue to turn them off and prevent them from forming tumors. The radiation is going to cause issues in the tissues, like even perhaps the bone, 59, 39, mostly, perhaps 238 in the spine. Hard to tell where it's going to show up because it's 5 to 7 years from now. So from an FSM perspective, you take one visit anyway to have this physiology of estrogen detoxification and to treat, to prevent the potential or possible estrogen-sensitive tissues. So this lady was on my left side, and I was in between the two tables. And the next patient was on my right side. So this lady was a 38-year-old female. She was diagnosed with endometriosis at the age of 18. And honestly, she'd had horrible periods since she was 12. So she'd had endometriosis since she started menstruating or shortly thereafter, but she was not diagnosed till age 18. I think she was 22 when she had a laparoscopy, and at about age 28 when she described the second surgery as a laparotomy, which allowed her to become pregnant. So these two surgeries allowed her to become pregnant. She had 3 children in 4 years, and all, I think, vaginal births, healthy kids. The kids are 8, 9, and 10, I think. She described herself as having a headache every single day for 20 years, so she's 38. She's had a headache every single day since she was 18. Her trunk, her posture, she cranked herself upright, but every physical therapist or massage therapist she's worked with has fussed at her about having her trunk flex forward, and it's a struggle to stand upright. Her resting pain was around a 4 or a 5. She was unable to tolerate touch on her abdomen, whether she did it. She didn't tolerate abdominal touch, so her children couldn't give her a hug. So if you think about what 7, 8, 9-year-olds, about their height, mom was about 5'6" or 7, and a 7, 8, 9-year-old come up and give you a hug, and their head comes just below her sternum. Her kids couldn't give her a hug. She could not tolerate that amount of pressure on her abdomen. That's the bad news. The good news was she had no pain with bowel movements. She had no pain with urination. She had no pain with intercourse. And in extreme cases of endometriosis and abdominal and pelvic pain, you will have all of the above, especially if they've had multiple surgeries. She has not had any surgeries, I don't think, for the endometriosis since these two. I don't think. We treated 3 cases of endometrial pain, endometriosis, abdominal, and pelvic pain. And to tell you the truth, they're all kind of confused in my head right now. But anyway, no pain with bowel movement, urination, or intercourse, which means that it's not that bad. She hasn't had a lot of treatment for it. Abdominal palpation she was +4 tenders, so the abdomen was firm, and you could not depress the abdominal surface of the skin. So when you went to depress, you lay your hand flat on the patient's abdomen, couldn't depress her abdomen because it was too painful. It just wasn't, it just wasn't tolerated. So we set her up with a washcloth in the back, a washcloth on her abdomen. Maybe it was a hand towel behind her back, washcloth in the abdomen. We had alligator clips from Precision Care for me and a Custom Care for the second unit. We needed to run the concussion protocol and emotional relax and balance concurrently with the treatment for the scar tissue and the pelvic pain and endometriosis. So we started on the left, which was the side that was less tender. So 13 and 77 was the frequency that liquefied the adhesions in the rats. There were 3 rats. When that softened up the abdomen, there were adhesions with the descending colon, 65, so 13 and 77, the connective tissue for the adhesion itself, 13 and 65 for the descending colon. Then when we got down to the sigmoid, so you're palpating the abdomen, and I can't emphasize enough the importance of a gentle palpation. You need to be able to feel what's going on, but when the patient tenses the muscles, when the muscles begin guarding, you need to just back off, just wait, okay? If you go in too firmly, there's a chance of tearing an adhesion. The muscles will splint and you're not going to go anyplace. So 13 in the sigmoid. And when we did scarring in the small bowel, scarring in the descending colon and the sigmoid, there's this taut band at the sigmoid, and it's running from the sigmoid, which is over on the left side in the lateral area, except the sigmoid was pulled a little bit medial. And when you followed that taut band, it led over to where you would assume the bladder would be. So look at Netter, get an idea about the anatomy. The uterus is posterior to the bladder, which is anterior, okay? So there's this band of scar tissue going from the sigmoid over to the bladder at 37. And you run 13 in the sigmoid, 129, and when you run 13 in the bladder, the distal end of the adhesion that's attached to the bladder, that liquefies. And so the bladder-sigmoid connection is now squishy. She described it as, when you palpate this tight band, I can feel the tight band, and then it's like a soap bubble that just bursts. It was a great description. So when the superior, the superficial soap bubble sort of burst and that melted, then we're down to the adhesion between the sigmoid and the rectum, the sigmoid and the uterus, 34, and actually the rectum and the uterus, 34. So we treated scarring in the uterus, scarring in the sigmoid, scarring in the rectum, and scarring in the sigmoid, rectum, and uterus, and that all melted. Once that liquefied, for want of a better phrase, then it became fairly obvious that the adhesion we encountered next was a little bit superior. And if you look at Netter, you'll see what the anatomy is. It's why you have Netter open to the belly when you do this treatment. The ovary is 7. Nobody had removed her ovaries. They just went in and cut up the adhesions and cauterized the endometriosis, and then scarring in the tube. So the ovary is 7, the tube itself is 4. And so then we went down towards the medial portion. Right. We went down sort of like from the ovary and the tube and the sigmoid and the rectum. We went into the center and the midline, and her pelvic floor wasn't moving at all. Now she's wearing jeans that are unzipped and just have a washcloth on her abdomen, but because the pelvic floor at the pubic bone wasn't moving at all, it was just rigid. On the outside of her jeans, I found the ischial tuberosities, and basically went next to the ischial tuberosities and sort of rocked the pelvic floor muscles and fascia, and with one hand on her belly and one hand was on her knees, one hand was on the ischial tuberosities. So from below, through her jeans, just sort of rocked and mobilized that tissue on the right, because I was sitting on her right, and then on the left, and just rocked it, so pushed superior to stretch and flex that tissue. 13 and 77, and honestly, I think I did 13, 142 as well. And that changed the pubic bone. The pelvic movement was now free. As I was doing this, she said she could feel it in her head. So feel it in her head, and she felt tingling in her feet as the pelvis moved. So we treated the left side of the abdomen, then I treated the pelvic floor, and as we moved the pelvic floor, she said, I can feel that in my head, and I can feel it in my feet. To me, that suggested the dura was involved. The dura attaches around the skull, all along the spinal cord, down to the sacrum and the coccyx. So when you move the pelvic floor and rock the pelvis, and you can feel it in your head, the only structure that goes from the pelvis to the head is the dura. So that guided the next step. 13 and 443, scarring in the dura. When the consumer book comes out, I recommend that you read it. The resonance effect. There is an intuition that comes with this class. Remember the little bird I told you that sits on your shoulder? There is an intuition that comes with this class, and I sincerely believe that that's where this inspiration came from. There's a logic to it, but it's like I reverse engineer the logic. So scarring in the dura, and we began, this is running just back to front at her abdomen. I did supine hip flexion, brought her knee up. Her knee went to less than 90 degrees. And ultimately, after a few minutes of running 13 and 443, scarring in the dura, her hip went up to maybe 110. Then we did the left hip with flexion. It still wasn't as free as it should have been, so put her knees down. So her knees are bent, her feet are on the table, but you have the knees as a fulcrum. And we began rocking her knees gently 1001, 1002, 1001, 1002. You want to work with the rhythm of the frequencies, and work with the rhythm of the frequencies, and that's a 2.5 second duty cycle. So about every 2 seconds, you're going to rock slowly, and her knees went from about 5 degrees of left rotation, 5 degrees of right rotation, to ultimately, after about 10 minutes or so, being able to rotate her knees over to about 70 degrees, not quite perpendicular. And that frees up the dura from the sacrum up to her head. She reported that her head felt free, her ears cleared up, and she could feel the difference, and the movement became much easier. After we did the rotation, you could then take her right knee almost to her chest, like maybe 130 degrees, and then her left knee to her chest. So then we went to the right side of her abdomen, scarring in the connective tissue, this 13 and 77. I think of that as taking care of the adhesions between the bowel and the peritoneum. Okay, the adhesion itself, 13 and 77, 13 in the cecum on the lower right quadrant, 13, that's 13 and 3, 13 and 31, the ascending colon, 13 and 22. There was quite a bit of adhesions in the small intestine. Then 3, sclerosis in the adipose. And that adipose is the omentum. So sclerosis in the adipose. If you think of the small bowel as kind of like a bowl of spaghetti, when the small bowel gets adhered, it's like the spaghetti gets all scrunched up in a bowl in the middle. As you run 13 and 22, the spaghetti begins to soften out and flatten and be like, you know, wet spaghetti with butter on it. It just sort of squishes around. The omentum sits in between the top and in between the small bowel, and it gets sclerosed. So the adipose sclerosis 3 with the adipose 97. So that would take care of the omentum. And once that softened up, there was still scarring in the ovary, 7, 13 and 7, 13 and the tube. And then it became obvious on this right side, there was scarring between the ovary and the tube. The uterus, 34, the bladder, 37. The bladder came first, and then we treated the ovary. Then we treated the uterus. Now, went down to the inferior pelvis near the pubic bone, and it was just sort of stuck. So 13 in the vagina produced no change, 19. And that's kind of to be expected, because if she had adhesions between the rectum and the vagina, or the bladder, or the uterus and the vagina, she would have had pain with intercourse, bowel movements, and emptying her bladder, and none of that happened. So 13 and 19 I did, but it didn't produce any change, and that was consistent with her clinical history. Scarring in the uterus, 34, scarring in the bladder, 37. And the palpation with this is you find the top band, it's tender. She would say, ow, it was nice. She didn't smack me. That was a good sign. And then it would just burst like a soap bubble. Then we went up to the upper abdomen. So she had adhesions between her diaphragm and her pubic bone. Her whole belly was rigid. Upper abdomen was 13 and 27, the transverse colon, 13 and 16, the transverse colon, and honestly, 284, I forgot about that, and 62. So deep old bruise. Endometriosis is a consequence of bleeding. 284 in the artery, the blood supply, 62, and 155 the endometrium. We did 13 and the endometrium, 155, didn't do anything. So that suggests that they actually might have done some good with the surgery and gotten most of the endometriosis turned around, but it didn't change the scar tissue. So depot bruise that reduced the tenderness. And then after doing all the scar tissue work, 18 and 62, we ran for about 3 to 4 minutes because anytime you're going to take apart this kind of scar tissue, there's a chance you're going to produce a bleed. So she was pain-free at rest, pain-free with palpation. The abdomen was soft and non-tender. And to tell you the truth, she was pretty stoned. Posture was more upright. The movement was free. And because her pelvis and her trunk is now different, like she was a good 1.5 to 2 inches taller than she was when she lay down on the table, like physically, because she could stand up straight. We demonstrated how to pull her shoulder blades in. I needed to teach her to walk again, or her brain was going to respond as if the abdomen was still adhered. So we get walking where you walk like a drum major, where you do, instead of heel-toe walking, you do toe first and then heel, toe and then heel. This gets information to your brain by a pathway that it doesn't actually expect. It doesn't listen to any information that comes in with regular heel-toe walking because it already knows what's there. Your abdomen's adhered, your pelvis doesn't move, your SI joints don't move, your dura doesn't move, nothing moves. So we did toe-heel walking, and that, probably 40 or 50 feet, so she did a couple of passes. And that began to normalize her gait. I use an activator. So CMT is chiropractic manipulative therapy. Activator is an adjusting instrument that stimulates the proprioceptors to change their tone or function. Activator to the pubic bone to loosen it up. It was sort of jammed stuck in the middle, which makes a certain amount of sense given what you've seen in the last few minutes. The sacroiliac joints, especially the left one, simply did not move. Once that started moving, so this happened as she was walking back and forth. Once we stimulated the proprioceptors to reactivate the sacroiliac joint, then I used the activator on her thoracic spine, adjusted with the activator her ribs and the posterior and the anterior part of the trunk, and everything started to move. And then Dr. Karbat suggested that we run 81 and 84. So we had the patient hold the gloves in her hands, and Dr. Karbat walked next to her, running the frequencies 81 and 84, just alternating. And as much as her gait had improved with just the physical retraining, toe-heel walking and the activator, when she ran 81 and 84, the patient's gait completely changed. She began to bend her knees, she began to move her hips, and she walked. She ended up having this, they get this puzzled look on their face, like, yes, they're moving differently, but they're not entirely sure why. And then Dr. Karbat ran 81 and 92 and got that turned around. So it was really fun to watch this. Now, follow-up over the next 2 to 3 days was she got some discomfort in the upper right quadrant of her abdomen the next day, but she had no abdominal pain. It was permanent, and her children could come up and hug her. So I treated her on Saturday night, and still there on Tuesday. So the feedback was Sunday, Monday, and Tuesday. By Tuesday, the children were able to come up and hug her. Her abdomen was still non-tender. This was like the high spot of the weekend. This was amazing. Oh, I forgot. Okay, we don't have time. I'll do this next time. This was interesting. Do this next time. There was a patient with radiation-induced scar tissue from tonsillar cancer. He was a former fireman, and much time?
I think it's 32.
Okay. I was a former fireman, and as he told stories he would get all choked up for like 3 or 4 minutes where he simply couldn't speak because he was crying or fighting crying. We treated the radiation and the scar tissue. He'd already had the concussion protocol run. But every time he started crying, we ran 40 and 89, just quiet down the midbrain. As soon as he stopped crying, we'd go back and treat the scar tissue. Over the hour and a half that we treated him, we probably, every time he told a story, we ran 40 and 89. So in the beginning, 40 and 89 ran for 3 minutes. So 89 is the midbrain, where the amygdala and the hippocampus tie these memories to a small, tie these memories to a vivid visual image in the amygdala. So there's a lot of emotional tie and a vivid visual image in the hippocampus. And 40 and 89 would quiet down that. So over the hour and a half that we treated him, this tearing up, choking up response went from 3 to 4 minutes down to about 30 seconds. At the end of it, he could swallow comfortably. We ran scarring in the pharynx, scarring in the esophagus, and radiation burns, and that was really fun. This last case, we're almost out of time. Like, I've got about 60 seconds, so I'm going to blow through this. You know how in the beginning of the course seminar, we run 94 and 200, 970 and 200 to see how students are going to respond? 970 and 200 I put in that sequence where the whole group is holding hands and the whole group gets treated. The student became lightheaded and dwarfed, but not in a pleasant way. She did not enjoy it. So emotional tension, 970 and 200, 94 and 200. Mental tension, it was the same reaction, but she described, this is key, she described a full feeling in her head that was not comfortable or pleasant. It was pressure. So 970 and 200, emotional tension. 200 is the frequency for the solar plexus. 94 and 200, mental tension. Once again, trauma in the solar plexus. Why would there be a pressure feeling in the top of her head? So 200 is an energy center at the solar plexus. What energy center is in the top of the head? Well, it's 102 is the crown center, right? So hypothesis, what if activation, 94 and 200, 970 and 200, what if activation of the solar plexus created a flow that was blocked by imbalance in the crown center, 102? It's the pineal gland, but it's also the energy center at the top of the head. So 35 and 102 is the frequency to balance the crown center. And we ran 35 and 102, and this sense of fullness in the top of her head went down, the pressure was relieved, and she felt better. She was no longer uncomfortable, no longer dwarfed, and she felt better, but she was still kind of lightheaded, I would say. So 6.8 and 38 was the next one on the list. She felt more grounded. But that left us with, why was the solar plexus so reactive? You don't need a history. I didn't need to do any sort of history or psychic questioning or history questions about trauma or whatever. The question is, why is the solar plexus so reactive? Okay, you have a frequency for balancing the energy centers. 35 and 1 on A is to balance the 102, the crown center. Well, 35 is balancing an energy center. Then you could run 200, the solar plexus on channel B, and 35 and 200, balancing the solar plexus, felt good, normalized the sensations. She felt grounded, comfortable, her face and her head cleared up. And then it was the end of the evening, so we ran 970 and 33, restoring joy, and she entered the exercise feeling really good. So here it is, a little bit after 3. I'm glad you joined us, and we'll figure out the technical portions of these webinars. I hope you get to listen to this on YouTube. and we'll see you next month. Thanks. Bye. Oh, wait. Join us for the Advanced and the Symposium in March. The Advanced is March 30th and 31st. The Symposium is April 1st and 2nd. It's our 20-year anniversary. The speaker list is stellar. Absolutely extraordinary group of speakers. Paris Carbot will be there. Neil Nathan is going to be doing a 3-hour segment on mold. Simon Yu is going to be talking about parasites at both the Symposium and the Advanced. Jim Oshman is coming and doing his stellar, unparalleled job of explaining how it is that FSM works. Diana Cross is going to be presenting her mechanism presentation. Kim Pittis is going to be presenting. Cliff Spohr is going to be talking about how to match up cervical spine x-rays and imaging with the FSM treatment that you choose. I know I'm forgetting people. Roger Billica is going to be the MC for the symposium. Don't forget that we have the Ruth Johnston Award at the Saturday night symposium banquet. We have the LEAP Award at the Thursday night advanced banquet. The cost of the banquets is included in the admission price of both the symposium and the advanced. So I encourage you to join us, and it's a tremendous celebration of what we and you have done in the last 20 years. The new book, The Resonance Effect, is not going to be out until April 24th, but we'll be doing excerpts and pre-orders. Books $15, $14.95. So you can order them, pre-order them for you and your patients, and look at the FSM website for a link to the Amazon link if you want to do pre-orders now. And Amazon's got a great summary of the book. It's been described as a page turner. I really had a great time writing it. So I hope this has been a good time for you as it is for me. And I will see you next month. Thanks a lot. Bye. Come on.